Hello, everyone, and welcome to our Essential Tremor Virtual Education Forum. Today, we're discussing essential tremor in pediatric patients. My name is Patrick McCartney, and I'm the Executive Director of the International Essential Tremor Foundation. Before we get started, I'd like to say thanks to our corporate partners, Medtronic, Abbott, Insightec, Sage Therapeutics, Jazz Pharmaceuticals, and Cala Health. Their support allows us to provide these webinars, our podcast series, and our quarterly ET education forums. Our speaker today is Dr. Keith Coffman. Dr. Coffman is currently Associate Professor of Pediatrics at Children's Mercy in Kansas City. He is also the Director of the Tourette Syndrome Center of Excellence, Movement Disorders, and Deep Brain Stimulator Programs, and has been a member of the IETF Medical Advisory Board since 2015. Dr. Coffman attended medical school at the Pennsylvania State University College of Medicine. He then completed residencies in pediatrics and child neurology, neurodevelopment disabilities at Children's Hospital of Pittsburgh. And this was followed by an NIH-funded postdoctoral fellowship where he studied the role of the cerebellum in voluntary movements and neuropsychiatric disorders. So welcome, Dr. Coffman. Thank you for joining us today.
Well, my pleasure. Thanks for asking me to do this. So from a disclosure standpoint, nothing in this talk is any product in which I have any financial interest, so I don't have any relationships to disclose in that regard. And most importantly, the medications we talk about, most of which are not FDA approved for treating essential tremor, especially when it comes to treating ET in children. So ET is one of the most common movement disorders on the planet, and based on work by Lewis and Ottman in 2014, it's estimated that about 7 million people in the US has essential tremor. That's actually over 2% of the population. When we look at pediatric onset ET, while ET is mostly thought of to be an adult condition, there have been numerous studies that show it does present in the pediatric population. In fact, estimates are that about 5% of all patients with ET will have present symptoms before adulthood. In some studies at movement disorder referral centers like mine, but we've not done such work, up to 20% of ET patients actually showed up within the pediatric years. And this is work by Dr. Lewis published back in 2007. Interestingly, and this is across all studies, even though ET, when you look at the overall experience throughout life, is a very equal male to female ratio, in all of the studies of pediatric ET, it's been mostly young men. This is shown by Dr. Jankovic in 2004, Dr. Lewis in 2005, and a very recent paper out of Germany in 2016. Not surprisingly, most pediatric onset ET patients have a family history of ET, and the data hasn't been really wide-ranging. It's been mostly between 60 to 80% of people have family members. And again, those same 3 studies are the ones that looked at this. Critically important, when we think about the way ET shows up in children, it's very different than in adults. Pediatric patients have mostly hand and arm tremor with very little tremor involving head, voice, or leg. And interestingly and thankfully, disease progression appears to be much slower in pediatric versus adult onset ET. The need for treatment of ET in kids is also very different than adults. And the data here are very wide-ranging, but you have to understand that studies in looking at ET in kids and treating ET in kids, the numbers are incredibly small. So the study by Lewis and colleagues back in 2005, they had only about 95 patients across 3 centers in the world: New York City, Birmingham, Alabama, and a center in the UK. And only 95 patients, so a quarter of them, about 25 patients, needed to be treated. When you contrast that to work done by Joe Jankovic and his group at Baylor, His patients population in the paper back in 2004 showed about 60% of patients needing to be treated with ET meds. However, that was 60% of only 39 patients. So again, very, very small numbers. And none of these have ever been replicated, showing really where the gap is in ET research in the pediatric population. So when we think about treating ET, we have to think about treating the symptom, right? How does the tremor affect quality of life? Kids have a different sense of how ET affects them compared to adults, right? One of the biggest things that affects kids with ET is it really affects their play, right? Think about trying to do Legos if you've got an action tremor that worsens with visually guided movements, right? Putting Legos together is an incredibly frustrating thing with ET. Think about puzzles or jewelry making or drawing, right? So this is where kids are going to express their frustration with ET in their play. They will be frustrated that tremor affects schoolwork, especially when it comes to, writing things down and getting critiqued about the way their handwriting looks. They don't often have as much frustration given the mild nature of their condition at that age with regards to things we typically think about with adults with ET that are a struggle, like dressing or undressing and eating and drinking. Thankfully, whenever it comes to treating ET in the pediatric population, many of my patients over the years have been very willing to use adaptive equipment to control tremor. So when we think about adaptive equipment for ET, it comes in a wide variety of forms, right? So if you need great control all day long, one of the best things to do is a pair of weighted wrist weights, okay? So these come in all kinds of very child-friendly presentations. So it doesn't matter if you're on Amazon or any other store, you look at wrist weights for children and they have designs that are very kid-friendly. They've got animals or characters on them. They come in a variety of different weights. And this helps the kids really, feel comfortable using this kind of adaptive technology. Also weighted pens and pencils, and these come in a variety of different ways. The most popular that my patients use is actually a weight that goes around a writing implement. So it's a big stone writing implement sort of sleeve. They put the pen or pencil in it, and it does two things. One, it weights everything down to make it easier, and two, it's a bigger grip so they don't have to push as hard on the small pen or pencil, and they can take the pen and pencil in and out. And then silverware, most pediatric patients don't need adaptive silverware, weighted silverware. I have some that do, and they really enjoy the ones that are weighted as opposed to the ones that sort of try to null the motion, okay? Why do kids like this? It gives them control, right? Their tremor doesn't control them. They are controlling their tremor, and they are therefore able to do the things they want to do without the tremor getting in the way. Also, the key thing here is they only use these whenever they're necessary, right? So if it's something that they're going through their day and their tremor only affects them playing with Legos, but everything else they do, they don't have to wear their weights, then that's perfect. When it comes to treating, and we're thinking about medication treatment, all medications have side effects. So what I think about whenever I talk about treating tremor in kids is, does the tremor affect life every single day, right? So the large majority of my patients don't have tremor that gets to the point where it's an everyday, all-day thing. And that's really the threshold we think about in terms of medication use in the pediatric population is it something that's going on and affecting life every single day? Also, when we think about ET in kids, some of the same conditions that are known to occur in ET in adults also happen in kids. Anxiety, migraine headache, Those are the big two that we see and that I see. And it's often the case that the medications that we would use to treat anxiety would also be helpful for controlling tremor, and same thing with medications for migraine. So if you have both conditions, ET and migraine, ET and anxiety, then that's another situation where it's like, okay, we can actually get two conditions under control with one medication. It's worth using medication at that point. So I have created over the past decade plus that I've been practicing neurologist, sort of my rules on when and how to treat kids when it comes to medication for movement disorders. Number one, let the patient drive the care, right? I can't sit in the office for 40 minutes and say, yep, I think you need medication based on what I'm seeing here. And it's often the case that we as parents think our kids need or want one thing, but when we actually ask them, they're like, no, this is really what I need or I want. So I tell patients, I don't live in your brain. I don't live in your house. I always ask my patient what bothers them the most. As parents, we intuitively, we want to help our kids. We see our kids struggling. We want to say, okay, he or she needs help with this. So what I do is say, okay, you heard what mom and dad said. This is what they think. Tell me, you're the one that lives in this body. Is this a problem? Is this not a problem? And if it is a problem, what kind of ways would we want to help you with it? And then I always target what the child identifies as the problem first, right? And then what we say is, okay, say mom and dad have one goal, child has another goal. We start with the child's goal. And if we don't get better, then we say, okay, mom and dad, your plan is plan B. We'll work on that if this doesn't work. Okay. So when it comes to treating, everybody's got to be on the same page, right? So, and we need to make sure that everybody knows about the associated condition. So every time I see a new patient with ET, I ask about anxious. Now, most kids don't know the word anxiety. And most people, when you talk about anxiety, have a conception of what anxiety is. So I never use the word anxious. So what I say is there anybody in the family who worries too much? Is there anybody in the family that has a problem falling asleep at night because they can't get their brain to shut off? So I ask about anxiety using sort of real life experiences and find a lot more anxiety than I would if I used the word anxious. Okay. Same thing when it comes to migraine, right? So I don't ask, does anybody in your family have migraine? Because most people have a preconceived notion of what a migraine headache is. So what I say is, does anybody in your family get headaches? Yes. If so, when they hurt, where do they hurt? What does the pain feel like? Does bright light or loud noise bother you when you have a headache? Do you get sick to your stomach, right? So never using the word migraine, I find a whole lot more migraine because I'm asking the symptoms as opposed to using the word, okay? And I'm a huge proponent of having kids be an active part in really driving their own care. Now, a lot of that has come from, a decade plus experience. It also comes from being a parent of now 3 teenagers who, often say, well, what I really think is important is this. So when it comes to treat pediatric onset ET with medication, there is precious few data regarding this. So ET, from a neurological standpoint, is one of the conditions that has a very robust practice guideline, most recently updated by the American Academy of Neurology in 2015. It has to be understood, however, that all the recommendations are based on adult data only. So let's look at the data and say, okay, what's recommended, and then is it pediatric safe? Is it pediatric appropriate? Okay. So the best medication options based on levels of evidence in the world of medical science are just like grades in school. A, B, C, those are your top 3 grades. So a level A evidence is, yes, this is very, very strong. Okay. So the two medications that have level A evidence for treating tremor are propranolol and primidone, okay? Both are well studied in kids for other conditions. So propranolol is one of the most widely used medications in pediatric medicine. It is used to treat heart rhythm differences. It is used to treat migraine headaches. It's used to treat a number of other conditions. It's safe to use down into neonates. So we know propranolol is absolutely a safe medication to use in treating kids with ET. When it comes to primidone, it is also an incredibly safe medication to use in children. It is a medication that's been around for decades. It is used to treat epilepsy. So both are incredibly safe when it comes to using. When it comes to side effects, propranolol has three big side effects. So fatigue, because it slows down heart rate, decreases blood pressure, it can make you feel fatigued. And because of the fact that it can slow down heart rate, folks can develop what's called exercise intolerance, right? So they try to exert themselves, but because propranolol sets your heart rate lower, you sometimes can't be as physically active as you would want to be. And this is a problem. Kids are very, very active, and we don't want to take that away from them. And then it can lower your blood pressure, which can make you prone to fainting, okay? So whenever it comes to dosing, low and slow is how I do it. Start at a low dose and then build up slowly. When it comes to primidone, because it's an anti-seizure medication and it works in the brain, the biggest thing is fatigue. All anti-seizure medications have the ability to make you feel fatigued because they decrease how fast nerve cells fire. And then any medication that alters the brain, like to control seizures, it has the potential to change mood. It's not a guarantee to change mood, it has the potential to change mood. Okay, the next level of evidence is level B. And here we have 4 medications that are listed as level B evidence. Atenolol, sotalol, gabapentin, and topiramate. And here's where things really change in terms of pediatric safe and appropriate versus not. So neither atenolol or sotalol have any good pediatric data for neurologic conditions. The pediatric data that's out there for those medications is for heart rhythm abnormalities and no really neurologic data at all. However, gabapentin and topiramate are well studied for other pediatric conditions, and in fact, topiramate has multiple indications for pediatric use. So when it comes to gabapentin, what are the side effects of gabapentin? So fatigue, dizziness, and drowsiness. So fatigue and drowsiness are different things. So drowsiness is, I'm going to fall asleep. I feel like I'm going to fall asleep. Fatigue is, I don't have any energy, okay? And that's where the difference is. And topiramate side effects, because of its chemistry, it can alter what's called your bicarbonate level. Basically, it makes your blood have more acid in it than it usually does. And as a result of that, that's part of the reason it can cause weight loss. And then the last side effect that we think about with topiramate is fatigue. In summary, ET does present in children, mostly present in boys. Most patients do not need medication therapy. Adaptive equipment use is always first line, and medications are used when those things don't work or when other conditions like anxiety or migraine require treatment. Thank you.
Thank you, Dr. Coffman. A couple questions for you that kind of come up quite often when we get calls from parents. First off is, what advice would you give parents in regards to accommodations at school for children with ET?
Yeah, that is far and away one of the biggest questions that we get as well, okay? So when it comes to ET and affecting school performance, we're really looking here at, does the child need what's called a 504 agreement? So a 504 agreement is part of federal special education law, which says that the student has a health condition that is impairing his or her ability to appropriately access their educational environment. Okay, so this is not an IEP. An IEP is basically a prescription for special education services. A 504 says, I have a physical difference or a healthcare difference that makes it hard for me to do schoolwork appropriately. So when we think about 504 accommodations for folks with ET, it can range from having text, sort of talk to text software instead of writing things down by hand, or being able to take notes by computer instead of writing down notes, sometimes recording lectures, or being able to have a copy of the teacher's notes. Because, you know, if you're trying to write and write quickly with your tremor, that's when things get in the way. And it's really a case-by-case basis, but the right way to access is to ask for a 504 agreement and work with your treatment team and your school district to say, okay, this is how ET gets in the way, and this is how we can accommodate the physical requirements of going to school in light of your movement disorder.
Great, thanks for that. Another question, this actually came up, I got a call just the other day, and I've not had this in the 5+ years that I've been here, but is there a minimum age requirement for a patient getting DBS surgery?
So yes. So when it comes to DBS for ET, there's very little pediatric data in terms of implanting for ET. So when it comes to age, we really use at our institution the age cutoff for another movement disorder called dystonia, because there is a very clear pediatric indication, and that age cutoff is 7 years of age. So anybody 7 years of age and older is FDA approved to be able to get a DBS for that condition. So that's really what we use when we think about DBS for ET. Now I can say, you know, in the 8 years that I've been here, we have only ever needed to think about and proceed with DBS for patients with ET twice. Both of those individuals have been severely disabled by their tremor, have had really no response to any medication therapy, including medications about which I haven't spoken. And DBS has been completely life-changing in a positive way for them and been able to wean off of medication. But yeah, that's the long answer to that question.
Well, great. Well, thank you for answering those questions. Those are ones we get. The DBS one actually is the only time I've ever received it, but the other one we get quite often. So thank you, Dr. Coffman, for taking the time to speak with us today and share some great information on essential tremor in pediatric patients. We hope everyone found this presentation helpful, and hopefully you learned something new today. If you have any questions regarding children with ET or essential tremor in general, please visit the IETF website at essentialtremor.org, or you can call us toll free at 888-387-3667. And finally, if you're a donor to the IETF, we thank you for your support. And if you aren't currently a donor, please consider a gift to help us continue the work we do promoting ET awareness, education, support, and research. We're going to be hosting a variety of virtual ET education events in the upcoming months, so look for notices for these events in your email, our social media, and our Tremor Talk magazine. Several of these events are currently posted on our website, along with some podcasts that we've been doing since September, so please check those out. And thank you again for joining us today, Dr. Coffman, and we hope you guys have a great day.
My pleasure.